or just going through these 4 areas, why we might be measuring it and what the evidence is, some technical aspects of the cervical length measurement and how we might integrate it into practice. Now, the rationale is that cervical shortening or effacement is an early change in the process of labour, and it can be quite a slow process that precedes labour by weeks or even months. The effacement begins at the internal os, and so it can be seen on ultrasound before it can be detected clinically. In fact, clinically looking at cervixes isn't really not that helpful. From there, we hope that if we're able to identify a short cervix on ultrasound, that will allow interventions that might decrease the risk of preterm birth. Currently, those interventions are vaginal progesterone, cervical cerclage, or in use in Europe, not so much in Australia, just in a very few places. There's something called an Arabin pessary, which tucks into the vagina and changes the direction that the cervix is sitting, and has been shown in some studies to be quite helpful in preventing preterm birth. And just note, out of interest, that rest is not there. Rest is not helpful. So this is a sort of table that you might see where the shorter the cervix and the earlier that shortening occurs, the higher the risk of preterm birth. But you can also see that even for a barely measurable cervix very early on, there's still only about maybe a 60 to 70% risk of preterm birth. So just because the cervix is very short does not necessarily mean that you go on to deliver preterm. So there's been a lot. I'm going to talk mainly about progesterone in terms of interventions, because cerclage, which is our other main intervention, is fairly invasive and is really kept for some limited indications for high-risk women. And what I want to talk to you about is screening in the low-risk woman. So there have been a number of studies looking at using vaginal progesterone for the short cervix in low-risk pregnancies. Probably the latest word is a meta-analysis published this year, looking at the 4 or 5 major studies that have been done. And they found that if vaginal progesterone was used for women with a short cervix, the relative risk of preterm birth was 0.66. And that was looking at the risk of preterm birth prior to 34 weeks or fetal death compared to placebo. And if you treated women with a cervical length of 25 millimetres or less, the number needed to treat to prevent one preterm birth was 11. No significant difference in neurodevelopmental outcomes between vaginal and placebo groups. And they concluded that it was reasonable to perform universal transvaginal cervical length screening at 18 to 24 weeks and to offer progesterone to women with a cervical length under 25 millimetres. And there have been other studies that have been shown that this is economically a good thing to do as well in terms of money spent, but a bit more about that later. So in terms of the technical aspects, really to see it well, it must be measured transvaginally. And a few points. The bladder should be as empty as possible. A full bladder will stretch the cervix, make it longer, and may potentially compress the cervix and make it and obscure any funneling, which will also make the cervix look longer. Now, the view that you're aiming for is a longitudinal view. You should just be able to see the corner of the bladder. It should be magnified so it occupies 50 to 75% of the screen. You should see the external and the internal os, and you ideally should be able to see the cervical mucosa, which points you to the actual cervical length. So here you see your external os here. I actually chopped it off, but you can normally just see the edge of the bladder up there, and you see the mucosa. Now, in fact, what this is showing you is that the mucosa ends here. So that, in fact, is your internal os. And here is likely to be a contraction that shouldn't be measured. You want to avoid excessive pressure on the cervix with your transvaginal probe, because once again, that stretches the cervix out, and you can just do that and measure it with the probe pressing against and then withdraw it, and you will see that it does actually make quite a significant difference to the length of the cervix. And so what you should do is get a lovely optimal image and then withdraw the probe until it just starts to blur, push it back a millimetre, and then that's your image with as little pressure on the cervix as possible, but you can still see things nicely. Now, caliper placement, as I said before, you want the internal os, what you want is the shortest closed length of cervix. So if there's funneling, as is shown in this one, you don't measure that. Or as I showed before, if there's a contraction, you don't measure that. You want the shortest closed length of cervix, but you don't want to measure beyond the internal os if there's a contraction there. Does that make sense? Good. So a word on funneling. The cervix, if it's going to be opening and shortening, it starts at the internal os, and so we get what's called a T-shaped first, turns into a Y shape, then as the os is barely there, you've got a V shape, and then as the cervix starts to widen above the os, you get a U shape, with the lovely mnemonic of trust your vaginal ultrasound. However, funneling in itself, certainly if the closed cervical length is over 25 millimetres, doesn't increase the risk of preterm birth. So it really is the closed cervical length that we're interested in. For short cervixes, there may actually be a slightly increased risk of preterm birth if there's funneling as compared to not, but it's really not that important. What we're interested in is the closed cervical length. You can comment on the funneling if you like. It's important to recognise that you can have mucus in the cervical canal, which may mimic funneling, and if you're not sure, you look for the membranes. If there's funneling, the membranes will be prolapsing down. If there's mucus, you've got the membrane sitting there. So really you should be measuring to the membrane if you can see it. If the cervix is curved and you just go internal to external os, and I'm sorry I don't have a slide to illustrate that, you will underestimate the length of the cervix. However, in practice, if a cervix is short, it's likely to be straight, and the curved ones are likely to be the long ones. If you're not sure, then they recommend just using two straight lines, so internal os to the middle of the cervix and then middle of the cervix to the external os. Very, very important, the cervix is dynamic. It changes with time. So if you look at the recommendations for cervical length screening, they will recommend that you take at least 3 measurements over 3 to 5 minutes and report your shortest measurement. And this series of pictures shows changes in the same cervix over a 5-minute period. And it can be quite dramatic if you just sit there and wait for a few minutes, the difference that you will see. Fundal pressure has been advised in the past to push down on the fundus and to mimic a contraction, but it hasn't been consistently shown to be helpful, and most guidelines don't recommend its use, for which patients are probably very grateful. You may see something called sludge, which is this sort of more hyperechoic fluid level sort of thing here that sits just above the internal os. What it is, if they've been able to sample it and test it, it's a cluster of bacteria and inflammatory cells, and it is significantly associated with increased risks of chorioamnionitis and preterm labour. So basically this shows you here your risks of preterm delivery with a cervix under 15 millimetres, no sludge, cervix under 15 millimetres with sludge, and then the same for the other groups. So you can see that the presence of sludge dramatically increases the risk of preterm delivery and makes us very wary of doing things like putting sutures in as well. So it's not that common, but if you do see it, please report it and be aware of it. Now, the current state of play, and this may change, but the current state of play is we really don't recommend routine measurement in the first trimester because it's poorly reproducible, it's very difficult to differentiate the internal os from the lower uterine segment, and also the studies that have looked at using progesterone, they don't normally start it till after 18 weeks anyway. There will be exceptions to that, women who are very high risk, where we might be considering putting in a cerclage around 15 or 16 weeks, we may want to measure it early. But in general, you know what, it actually just creates problems. It creates problems when somebody's measured it and says, oh, it's 45 millimetres at the 12-week scan, and then I go and measure it at 16 weeks and it's 35 millimetres and the patient has kittens because she thinks it's already shortened that much, and in fact, it's just that it's difficult to measure early on. Multiple pregnancy, really, really controversial. But once again, probably not to be done as a routine thing, just in your general radiology practice. There might be reasons to or reasons not to. It has a low sensitivity for preterm birth, as in a long cervix is not reassuring in multiple pregnancy. Although a short cervix in a multiple pregnancy is significantly correlated with an increased risk of preterm birth, most of the ordinary interventions we have not actually been shown to be helpful, and so it can just create anxiety, although it may be helpful perhaps for interventions such as steroids or making sure that a woman is close to hospital. Even then, yeah. So if you're out in the general radiology practice, please don't measure it in those circumstances. So, practical considerations. The 25mm cutoff, in different studies it's been variously reported as a 2nd, 5th or 10th centile at 20 weeks. So if the number needed to treat to prevent preterm birth is 11, the number needed to screen to prevent one preterm birth will be somewhere between 110 and 550. Which is a lot of women. If you're going to measure it transvaginally on everyone, you've got your 3 to 5 minutes of scanning time that's recommended, and you've got time to get undressed, empty your bladder, come out, get arranged, get dressed again. It'll take about 10 minutes on average. So for every 4 patients that you scan transvaginally, that's probably 40 minutes of your time, and that will equate to maybe 1 whole morphology scan. And so I guess this is what we're struggling with. The studies that show it makes economic sense to do routine cervical length screening assume that the same people are paying for the cervical length screen as are paying for the preterm, for the neonatal nursery and the complications of preterm birth. And that's just not the case here. If you're spending an extra 40 minutes to do 4 patients, the government's not paying you any extra, your practice is paying, and you're not benefiting. So then there's interest, if you're going to be looking at cervical length, can you screen transabdominally, which is obviously going to be a lot quicker than doing a cervical length transvaginally. It's obviously not going to be as good, but can it be nearly as good? So there've been a bunch of studies that have looked at this, and their results have been quite conflicting. But some studies, and they tend to be the ones that have looked at measuring the cervical length after voiding, have shown that a cut-off of 30mm transabdominally is pretty sensitive for picking up a transvaginal length of under 25mm. Others have not agreed with that. It seems that doing it with a full bladder tends to, by stretching out the cervix, cause an overestimation of the transvaginal length and isn't such a good screening process. Others have showed no difference between full and empty bladder. So I've sort of asked around Australia what people are doing in their practices, and some say you just cannot screen transabdominally, you must do it transvaginally, there's no point at all transabdominally, and they do it. Others will use a 35mm cutoff transabdominally, but if you do that, you're going to be scanning about 60% of your women, because either they're under 35mm or you can't see it well. And in general, it's about 15% that you can't see it well. So at Women's Imaging, we've discussed this. We've decided to screen transabdominally and to use a 30mm cutoff because we think that's defensible in view of those studies. We report the cervical length. We say whether it was done transabdominally or transvaginally. And from my point of view, if the obstetrician says, oh, 33mm transabdominally, I'm not happy with that in view of the current evidence, they can either send them back to get it done as a separate study or they can do it themselves. It's just pragmatic, you know. But this is what you're looking for with a transvaginal scan. You want to be able to see the internal os, the external os, you want to be able to see the canal. That's inadequate because the internal os is obscured by a fetal part, but you can presumably wait for that fetal part to move away or push it away. That's inadequate because the external os is shadowed. So There are no definitive Australian statements on what to do. ASM very helpfully says the cervical length should be assessed. Or, no, in fact, I think it says the cervix should be assessed. So our approach is, if it's requested or if there's a history of preterm birth or uterine anomaly, as in they're high risk, we will go straight to a transvaginal scan. In theory, we'll do a transvaginal scan if the view is suboptimal. I suspect we probably squidged that a bit, and we're about to do an audit on that. And we do that also if the transabdominal length is less than 30 millimetres. So look, you know, I'm afraid I can't tell you actually what the answer is, but that's where we're at. I don't know, Sophie works in an ultrasound practice in Melbourne, so she may have something else to add to that as to what they do, but it's difficult.